Hello, everybody. Thank you for your attendance. Thanks to the conference committee for inviting me to attend today. Thanks for our dear professors. One day in the ICU unit I'm working in, there was a child who was admitted after a traumatic brain injury. He was ventilated, and suddenly the ventilator started to scream. The patient was not ventilated well. There is high peak airway pressure and there is a diminished air entry on one side, and the patient was desaturating. The residents and the assistant lecturers thought about pneumothorax and requested a chest x-ray that was delayed. So they started to think about inserting a cannula in the mid-clavicular line to decompress this pneumothorax. We started to perform a lung ultrasound, and this what we saw. This is a sign that is called lung pulse. Lung pulse is a pulsation of the lung tissue that transmits the cardiac pulsation, and as we see here, the parietal and the visceral pleura are sliding, but not due to ventilation, due to the cardiac pulsations. This indicates a main bronchus obstruction or a main bronchus intubation on the contralateral side. What we did, we started to suction the endotracheal tube, we changed the endotracheal tube, we performed a bronchoscopy, and then the patient turned comfortable on the ventilator. And fortunately, this patient discharged 2 weeks later completely normal. Our lecture today is point-of-care ultrasound in pediatrics, anesthetic applications. I'm Dr. Muhammad Yassin, lecturer of anesthesia, surgical intensive care, and pain management, Cairo University, diplomate of European Society of Anesthesia and Intensive Care, and a fellow of the College of Anesthesiologists in Ireland. The objectives are introduction to Pocus, Pocus spectrum, Pocus in pediatric anesthesia, lung ultrasound, echocardiography and inferior caval assessment, ultrasound-assisted procedures, abdominal ultrasound, and airway ultrasound. Pocus is a bedside ultrasound examination, and this is very important. In the critical situation, you don't have a long time to investigate the patient. So the ultrasound can give you an alternative for many procedures. So it is easily accessible and portable, gives excellent image resolution in pediatric population and better penetration due to smaller body habitus. Offers rapid and dynamic assessment in critical situations. So you can detect the abnormality, you can intervene, and you can follow up the intervention. And the lack of ionized radiation. A lot of patients, especially the neurosurgical and burn patients, can stay in the ICU for months. So repeated exposure to ionized radiation can be very harmful to this population. This is a study that was done in pediatric emergency medicine that's not away from the anesthetic practice. The use of point-of-care ultrasound improved diagnostic accuracy, decreased the length of stay in the emergency department, and improved the overall patient satisfaction. The spectrum of point-of-care ultrasound, what we can use the ultrasound for in the pediatric population, we can use to examine the lung ultrasound. We can do an echocardiography, inferior vena caval assessment for fluid responsiveness. We can use fast examination to diagnose an abdominal collection or to follow up an abdominal collection after trauma. We can use it for ultrasound-guided procedures, which is a very wide field in the pediatric practice, airway ultrasound, and lastly, transcranial Doppler that can be used to detect the cerebral blood flow or the flow in the middle cerebral artery. We will concentrate on the most commonly uses or the most common uses of ultrasound in the pediatric anesthetic and intensive care practice. First, lung ultrasound. It's very long time that we know about ultrasound, but it was thought that ultrasound will not be a good tool for examination of the lung. As you know, ultrasound has an enemy, which is bone and air. So the lung is full of air, so the ultrasound cannot penetrate the lung tissue. But recently, we found that there is patterns or artifacts that can be helpful in diagnosis of many abnormalities. So lung ultrasound is an interpretation of artifacts. The technique of performing ultrasound, we can use the linear probes, the high frequency probes. You know, there is a different probes with different frequencies. The higher the frequency, the higher the resolution, but the lower the penetration, and vice versa. The lower the frequency, the higher the penetration, but the lower the resolution of the image. So as we see here, this is a linear probe. There is a very good visualization of the pleural lining, so we can use it for detection of any pleural abnormality. You can see that the depth here is 4 or 5 centimeters, no more. We can detect any pleural abnormality. We can detect any subpleural abnormalities, but no more than this. We can use the lower frequency probes like the phased array probe that is used in echocardiography. This gives a better penetration but a lower resolution. So you can see here that we have a lower visualization of the pleural lining. But we can see here that we have a thickening of the pleural lining, and we can see an artifact here that's called B lines or confluent B lines. That indicates there is an air fluid interface. This indicates an increase of extravascular lung water and alveolar edema, and this can help in diagnosis of the condition and assessment of the severity in the context of the clinical situation. The scanning areas, we can, there is a lot of protocols for scanning of the lung. We can scan every intercostal space, or we can scan 12 areas. 4 in the anterior chest, we can draw a transverse line connecting the nipples and passes posteriorly, and examine the anterior chest in 4 areas between the parasternal line and the anterior axillary line, above and below the transverse line. These are 4 areas. In the lateral areas, we can examine the lung between the anterior axillary and posterior axillary lines, above and below the transverse line, and posteriorly we can examine it above and below the transverse line between the posterior axillary line and the interscapular line. Now we will talk about the lung ultrasound artifacts. Here you see the pleural lining indicating the presence of the visceral and parietal pleura. This is the skin, intercostal muscles, subcutaneous skin and subcutaneous tissue, intercostal muscles, and the pleural lining. Dynamically on examination, you can see this sliding with movement, indicating the movement of parietal pleura over the visceral pleura. This indicates a normal pattern. The A-lines are artifacts. As you see here, it's a reverberation of the pleural lining, and the distance between the A-lines is equal to the distance between the pleural line and the probe. So this indicates the presence of a lung tissue in this area. As you see here in this video, this is the pleural, the skin, subcutaneous tissue. Subcutaneous tissue, this is the pleura sliding. And you can see the A lines here, the distance between the A lines and each other is the same between the pleura and the probe. B lines are laser-like lines extending from the pleural lining to the periphery of the screen. This indicates the presence of air fluid interface. It can be an interstitial lung water or alveolar edema. According to the severity, we can indicate if this is interstitial, as we see here, and if it is confluent, we can indicate, or we can say this is an alveolar interstitial pattern. These are the B lines. These are laser-like, extending from the pleura to the end of the screen, and they are dynamic, moving with respiration. The presence of more than 2 of these B lines indicates interstitial lung water, and you see the difference between the normal and the abnormal patterns. Lung ultrasound patterns, we can use these signs to make a diagnosis. You can see here, this is a pleural lining, this is A lines. There is maybe there is discrete B lines less than 2, and there is pleural sliding. This is a normal pattern. The interstitial edema pattern, there is a normal pleural lining and multiple B lines. This indicates interstitial water, interstitial lung water. Alveolar interstitial pattern indicates interstitial lung water and alveolar edema. So you can see here a thickened pleural lining and confluent B lines. This is a white lung. This indicates severe congestion or severe edema. So you can use it to diagnose pulmonary edema, ARDS, and so on according to the clinical context. The consolidation pattern, you can see first the shred sign. The shred sign, you can see the pleural lining here and the pleural lining here, and then there is a defect or hypoechoic area. This indicates a subpleural consolidation, and you can see a white area here. This is hepatization and white dots, which indicates air bronchogram or collapsed airways. So this is subpleural consolidation. The pneumothorax, and this is one of the most important uses of lung ultrasound, it has an increased sensitivity and specificity over the usual X-ray, chest X-ray. You can see the what's known as the abnormal pleural sliding and the absence of B lines. So the absence of lung sliding and absence of B lines, this can help to diagnose pneumothorax, but one of the most important signs and one of the definitive signs for diagnosis of pneumothorax is the lung point, which is the detection of the edge of pneumothorax. While you are scanning the different areas, you can reach this point where you have a pneumothorax in one side and a sliding pleura on the other side. So this is a sure sign for diagnosis. So there is absence of pleural sliding, absence of B lines. There is a lung point, which a point separating an area of a pneumothorax and the normal lung. And on M mode, if you use the M mode, this is a continuous ultrasound concentrated in one point. Over time, you can see the barcode sign as shown in this video. You can see here this is an M mode. You can see the barcode sign, and there is a normal lung here. There is a normal sliding here, so this point is the lung point, and it's a sure sign for a diagnosis of pneumothorax. Obstruction of the main bronchus. Here we see the lung pulse. There is pulsations of the pleura, indicates that there is movement of the lung with pulsation, but not with air entry. So this diagnosis of obstruction of the main bronchus or intubation or bronchial intubation of the contralateral side, you have here to exclude pneumothorax. Pleural effusion, this is a scanning of the inferior lung region in the lateral view. This is the liver, this is a diaphragm, this is an hypoechoic area indicating the presence of the fluid, and this is a collapsed lung floating in this fluid. So this is a diagnosis of pleural effusion that can be a chylothorax, hemothorax, according to the clinical context. So this is an echoic collection between the pleural lining and the floating lung. Here is known as the jellyfish sign. As you see here in this video, this is the liver, diaphragm, the pleural effusion, and the jellyfish sign. Clinical appeals regarding the use of ultrasound, lung ultrasound diagnosis it can help in diagnosis of pneumothorax in a bedside way, detection of subpleural consolidation associated with ventilation or pneumonia, detection of pleural effusion and helping in drainage, increase the extravascular lung water that can help in diagnosis of the condition and to guide fluid management, diagnosis of hemothorax if this effusion in the context of a trauma, so it can be hemothorax, assessment of airway equality during intubation to detect the equality on each side, or if there is an obstruction of the main bronchus by a mucus plug. Guidance of therapy. If you detected an abnormality in the lung and you started an intervention, you can follow up with lung ultrasound in a bedside way. Echocardiography and IVC assessment. You can use echocardiography in anesthesia and intensive care to assess the adequacy of contractility, adequacy of the filling of the ventricles. And you can diagnose a pericardial effusion or pericardial tamponade, which is very important in the trauma situation. The IVC assessment, you can see here the IVC, you can see a collapsile inferior vena cava, which indicates a hypovolemic patient. This is a non-collapsile IVC indicating fluid unresponsiveness. Regarding the ultrasound-assisted procedures, we can use it for arterial cannulation, for insertion of central lines. You can use it for guidance or detection of a appropriate nasogastric tube insertion. This is a view, an airway ultrasound. This indicates the trachea, and this is the esophagus, and this is the artifact of the nasogastric tube. This is an ultrasound of the stomach. This is the left lever lobe, and this is the stomach collapsed, and this is the gastric tube. Abdominal ultrasound can be used in the context of fast examination to detect an abdominal collection, as we see here, a hepatorenal collection, a collection between the right kidney and the liver, or even a follow-up for a patient with abdominal blunt trauma. If you have a patient with anuria, you don't know if this patient has renal failure, or there is an obstruction of the urinary catheter, or there is a false track urinary catheter, so you can use ultrasound to detect fluid in the urinary bladder and to detect the catheter inside in a correct place. An airway ultrasound, this is a very important area, and we have a growing evidence regarding its use in this context. We can use it for assessment of the endotracheal tube placement. You can see here a tracheal rim, and there is an artifact of the endotracheal tube. You can use even the Doppler or the Doplex to detect the airflow in this area. And this is an ultrasound view of esophageal intubation. There is two hypoechoic areas indicating the trachea and the esophagus, and you can see here the endotracheal tube in the esophagus indicating an endoesophageal intubation. The assessment of endotracheal tube size, this is very important in the pediatric practice, not to especially in prolonged intubation. You can use it for detection of the correct size. The cricoid cartilage, which is the narrowest area in the pediatric airway, we can use the ultrasound over the cricoid cartilage to detect the diameter of the cricoid, and then we can detect the appropriate size. Ultrasound-assisted cricothyrotomy, we can use ultrasound in performing cricothyrotomy or even tracheostomy. First, we will start scanning the thyroid cartilage. As you see here, this is the thyroid cartilage, and this is the vocal cords. Then we will sweep caudally. We can see here the cricothyroid membrane. This is an air mucosal interface, and there is no cartilages over this area. This is the thyroid gland. So we can use this area for insertion of the needle. We can use the Doplex to avoid any vessels in this area. If we sweep the ultrasound much caudally, we can see here the cricoid cartilage, and we can use it for detection of the diameter of the cricoid and the diameter of the appropriate endotracheal tube. So we talked about introduction, about the point-of-care ultrasound, point-of-care ultrasound spectrum, uses in pediatric ultrasound, in pediatric anesthesia, lung ultrasound, echocardiography and IVC assessment, ultrasound-assisted procedures, abdominal ultrasound, and airway ultrasound. Thank you for your listening and wishing you a nice day.